You have undergone an hysterosalpingography test and your doctor has told that your fallopian tubes are blocked. There is less chance that you can conceive naturally. You get worried. Does that mean you cannot conceive naturally? Does that mean that this fallopian tube is actually blocked? Does that mean that you would need IVF only? Good morning, I am Dr. Rajat. In this video, I will tell you that blockage on HSG does not necessarily mean that your fallopian tubes are blocked. There are ways that the fallopian tubes may be open. And by the end of this video, I will tell you how to interpret it. You will learn how to interpret an HSG, how to interpret the X-ray of an fallopian tube, how to conceive if your fallopian tubes say that they are blocked, and how to conceive naturally without undergoing IVF. Good morning, I am Dr. Rajat. I am a fertility gynecologist and I have started watching our YouTube channel, The Fertility Gynecologist. So like I said in my previous video, we discussed about hysterosalpingography, that is the X-ray to know whether the fallopian tubes are patent or not. Now in this video, we would discuss the results of hysterosalpingography. Like I started in my video, you have undergone an HSG and your doctor has said that your one fallopian tube, for example say right fallopian tube, is blocked. Then you are under tension. You come to the doctor, what to do now? Now first and foremost, I'll go back to the basics. For a female to conceive, she needs uterus, ovaries, fallopian tubes and sperms. The function of fallopian tube is to transfer the egg which is released. It gets picked up by the fallopian tube. Sperm goes from the vagina, it goes through the cervix, cervical barrier, through the cornu, and then it goes to the middle part of the fallopian tube. Middle part of the fallopian tube is the part where the fertilization, that is the union of sperm and egg, takes place, and that fertilized embryo remains in the fallopian tube for a couple of 8 days, and then it migrates to the fundus. So the only function of fallopian tube is transfer of eggs to the fallopian tube, transfer of sperm to the fallopian tube. If fallopian tube are not open, then the female cannot conceive. Now for example, if the right side fallopian tube is blocked on HSG, does that mean that you cannot conceive? Answer is no. You can conceive if your egg ovulates from the left side. That means that everything is fine, that you can definitely conceive. The only thing is average. If a female is trying for a conception, then usually they say that ovulation occurs on the alternate side. If 1 month it has occurred on the right side, then the other month it may occur on the left side. So if on fallopian tube, allegedly, why I am saying allegedly, I'll come to it in the later part of the video. If only left side fallopian tube is open, then the percentage chances of pregnancy per month would decrease by half. And like I always say, the cumulative pregnancy rate, if fallopian tubes are open, if sperm counts are normal, uterus is normal, and the hormones are normal, then in those cases the per cycle conception, natural conception chance is about 4 to 7% per year. Cumulative chances of pregnancy are about 80%, and in 18 months to 24 months, the cumulative pregnancy chance is about 90%. If the fallopian tube one side is blocked, then the chances decreases by half, but you can definitely conceive provided the other factors are normal. So take one fear out of your mind that if your one fallopian tube is blocked, you may not conceive, you may not need IVF. That is a absolute piece of a bullshit. You can definitely conceive. Now coming to the most important thing. I mentioned in my previous video, most of the doctors, most of the radiologists who are doing HSG, what they do, what I have found in the last 20 years of my practice is, they inject the dye relatively fast, and also they give the painkiller Voveran and atropine injection just before 5, 10, 20, 30 minutes before doing the HSG. These are the two bottlenecks which I have found, that because of them, A, it causes maximal amount of pain, and B, it provokes the spasm of uterus. I mentioned in my previous video, this is the LW cannula. Some people prefer the plastic cannula, or some prefer the Foley's catheter, but I prefer this metal cannula. Why I prefer this metal cannula? A, because like I mentioned, these are the serrations that snugly fit into the cervix. So whenever I am putting the dye inside, the dye will not be able to come out, or if it may come out very slowly. The capacity of uterus, like I mentioned, is only about 0.8 to 2 ml, maximum 0.8 to 2 ml in females who want to conceive. And the moment I am injecting dye, which is more in volume, because uterus is a muscular organ, the moment a sudden gush of the volume comes, it expands and it provokes a spasm reflex. Any smooth muscle, circular muscle in body is prone to spasm, and that is why it promotes a spasm reflex. And the moment I push the die very fast, because the cornual openings are very small and this opening I have blocked, so the uterus may go into the spasm, the muscles of the uterus may contract tightly, and as a result, sometimes what happens is the cornual spasm occurs. Cornual, like I mentioned, is the opening inside the uterus on each side, and this spasm occurs. So in 90 to 95% of the cases in which we see that the dye does not come out from this side, and the dye is only till the cornu, and in other side the dye has come out, then I document that thing in my case papers as a cornual spasm rather than a cornual block. I then inquire to my patient, was there excessive pain? How long the pain was there? So in those kind of cases, I mention in my case paper that I would consider this fallopian tube to be open unless I confirm it by some other method. Which are the other methods? I'll come to it later in the video. So to prevent this cornual spasm, we have to give diclofenac and atropine at least 1.5 to 2 hours. This is what I have been practicing since last 20 years. I have done almost close to about 5 to 7,000 HSGs. Yes, couple of my patients do have pain, but those patients either have got fimbrial tube block or a mid-tubal block or a cornual block. Those patients have got pain. The mechanism of pain is simple. If I am putting the dye here and if this fallopian tube is patent, the dye would come out. It won't provoke the spasm of uterus and patient will have absolutely no pain. But if there is some kind of a dried mucus or dried sludge inside the fallopian tubes, then at the time of pushing the dye inside, this sludge may, while the moving of the sludge may cause pain, it may cause the contraction, and it may sometimes, in spite of the fallopian tubes being patent, it may cause the pain in the lower abdomen. Or if there is a fimbrial tube block, or if there is a cornual block, in those cases the dye may not come from either one side or from both sides depending upon the case, and that may prove to be spasm in most of the cases, in spite of giving diclofenac injection couple of hours before, in spite of injecting the dye slowly. So you have given the dye slowly, and in spite of that, there is the patient comes to me from outside with a report of a cornual single fallopian tube block. I see the X-ray, and in X-ray there is a single side cornual spasm. What do I do in such cases? I consider that case as normal. I document that there is a possibility of a cornual spasm. We try for normal pregnancy for another 3 to 4 months. I give a liberal course of antibiotic. For me, when I mention antibiotic, especially in infertility, especially in cases of tubal block, tubal infertility, I only use doxycycline 100 mg twice daily for 7 days, 10 days, 20 days, depending upon the case. And excessive use of pre and probiotic, I rotate the different strains of probiotic, and I ask the patient to try for a natural intercourse for a couple of cycles. If within next 3 cycles patient does not conceive, then with proper counseling, with proper painkiller and antibiotic, with my technique, I again repeat the hysterosalpingography. And out of 100 cases of cornual spasm, what I have found is in about 80 to 90 cases, both the fallopian tubes are found to be patent. So this is about a single side cornual block. Sometimes there is a bilateral cornual block. Now, mind you, bilateral cornual block can also be a spasm, but there are more chances of there may be a pathology in those cases, but still we can try for this technique. But bilateral cornual block is more likely to be some kind of a pathology. If patient has undergone dilatation and curettage, or patient has undergone delivery, or patient has gone multiple abortions, or patient has undergone C-sections, there are chances, or patient has undergone myomectomy, there are chances that during those surgery, the endometrium, the excessive curettage around the fundus or around the cornu, or during C-section, some doctors have a habit of curettaging the uterus, or with a swab holder they clean the uterine cavity, or during the myomectomy, if the fundal myomectomy is near the cornu, then during the separation the endometrial cavity may have been opened. In those cases, after the healing, during healing, the fibrosis of the cornu may have occurred, and that may lead to the cornual block. So those are the things we have to take care of. Now in some cases, I always insist on seeing the X-ray plate of the patient. In some cases the dye comes and it sometimes stops at the mid-tubal level. In one side complete patency is there, but in one other side the mid-tubal dye only reaches till the mid-tubal segment. Those are the cases which are not good as far as the tubal infertility are concerned. Mid-tubal dye means there is a definite damage to the cilia of fallopian tube, and that cannot be treated either with medicines or with surgery. Mid-tubal block mid-tubal block cannot be treated with surgery. The only option left with mid-tubal block is if for some reason patient decides to go for laparoscopy, either for myomectomy or for fertility enhancing laparoscopy surgery or for endometriosis or for ovarian cyst, then that fallopian tube should be removed with prior consent of the patient, because mid-tubal block most likely is not going to be treated surgically. There is no option available to us, either salpingostomy or fimbrioplasty, which can repair the fallopian tube in the mid-tubal segment. That is why seeing the X-ray is very, very important. Sometimes what happens is dye comes till the fimbria, but there is no free flow available. I always advise gynecologists to see the X-ray themselves, not to rely on the radiologist report. If the dye comes till the fimbria, but you are not able to see the free fluid, then it means two things. Either the dye you may have injected was less, or somebody may have injected was less, or there is a fimbrial block. Now again, like I mentioned, if there is a absolute complete fimbrial flow, free flow of the dye from one side, but at other side the dye has come only till the fimbria and there is no free fluid of the dye. In those cases, what I do, like I mentioned with my Cornual spasm, again I give a liberal course of antibiotics. I counsel the patient that there is a 50% likelihood that this dye may be patent, so we may try naturally for 3 to 6 months. Since your other fallopian tube is patent, we can try for 3 to 6 months, and after 3 to 6 months of liberal antibiotic and probiotics, we will again repeat the dye. And like I mentioned, for me the master key is 50 ml dye I inject, because what I have experienced is when I put the dye inside, sometimes radiologists say most of the when I am taking the 10 ml fallopian tube only, normally people take 5 ml media HSG dye with 5 ml normal saline and they inject up with the LW cannula. Suppose I need to take another X-ray, then I have to remove that syringe from this dye, from the LW cannula, and during the removal of that process, whatever the dye is inside the cavity or inside, it comes out again. So when I am taking a 50 ml syringe, initially I inject only 10 ml, but I keep this LW cannula, this syringe fitted with the LW cannula inside the uterus, and let radiologist see the X-ray. If radiologist says you have to inject the dye again, that dye which I have already injected is already in the system, in the uterine cavity, in the cannula, so I have not to inject again whole dye, I just have to inject 5 to 10 ml. The advantage of this 50 ml cannula is the more dye I inject, sometimes what happens is there is a hydrosalpinx, so the more dye can be accommodated in the fallopian tube. So if the dye is injected and it accumulates here, sometimes hydrosalpinx fallopian tube may be patent. There may be a mild or a moderate hydrosalpinx, they may be patent, but there may be a collection of dye, so that may require more dye. So like I said, if the fallopian tube reaches only up to the fimbrial end, my assumption would not be directly to go for a laparoscopy. My advice would not be directly to go for a laparoscopy. I would counsel the patient, we try for couple 3 to 6 cycles more. If next 3 to cycles you do not conceive, I would again go for a repeat hysterosalpingography with all the precautions and with more dye to be injected. There is 50% chance that if I inject more dye, then this dye may actually be patent. If there is a Cornual spasm, I repeat the dye after 3 months. If there is a mid-tubal block, I may or may not repeat HSG, because mid-tubal block usually is the worst as far as the treatment outcome is concerned, and in my experience, you have to go for a salpingectomy. Though it is not an emergency, but whenever you go for a laparoscopy or a hysteroscopy, or if you are planning to go for IVF, you have to get this fallopian tube removed, because this fallopian tube is not going to be of any help, but it can be of impediment as far as a pregnancy is concerned. What may happen is, if there is a mid-tubal block, the fluid may collect till this portion, and this collection of fluid may go inside the fluid may collect in this portion, and this collection of fluid may go inside the endometrial cavity, and it may not help with the implantation of embryo. If the dye has come till the fimbria and there is an apparent fimbrial block, we have done HSG 2 times, or I have again repeated the HSG in spite of injecting more dye, the fimbrial block is there, then the options with us are a laparoscopic fimbrioplasty, opening of the dye. So what we do is, we take the patient for a laparoscopy, we try and open the fimbria, and we try and create a neofimbria so that it does not close back again. So fimbrioplasty, maintaining of a the refashioning of a normal tubo-ovarian relationship is an important thing that should be done. If there is a Cornual block which is definite, then what we can do is, we can do a hysteroscopic guided cannulation. what do we do is we put a camera inside the uterus and we look for the cornu, and there is a cornual cannulation wire available. It is something like this. We take this wire inside and we try and put inside the cornu, and with this wire we try and open the Cornual block. Normally the Cornual block is a minor adhesion, minor band, which can often be opened by this. We can do it on both the sides, but I feel that the moment fallopian tubes are very soft, the moment you do cornual cannulation, it may open sometimes, but it may also injure the cilia and the inside part of the fallopian tube. For that moment, if you repeat the tubal chromoperturbation test during laparoscopy, yes, it may be open, but there is no guarantee that 4 weeks, 6 weeks after it will remain open, because most of the tissues in our body, they heal by fibrosis, and there is a good chance that it may again close. But there is no option. If you are taking the patient for a surgery, you try cornual, you have to try cornual cannulation. Some people, the expert laparoscopic surgeons, they also do something called as a salpingoscopy. Salpingoscopy is that we put the camera inside the mucosa of the fallopian tubes. This salpingoscopy is done to check for how healthy the mucosa, the cilia of the fallopian tubes are. It gives us an idea as to whether the fallopian tubes are potent or patent. I discussed in my previous video, there is a difference between patency of fallopian tube and potency of fallopian tube. Fallopian tube is not only a physical organ which needs to be patent, but it is not only an anatomical patency which is required, but a functional patency is required. I mentioned in my previous video that there are various cilia, they are hair-like structures. These hair-like structures transfer the egg from the fimbria to the middle part of the fallopian tube, and wherever the cilia are damaged, from there the egg cannot transport, and if the egg does not transport, sperm is motile on its own, sperm can come to that place, it can fertilize the egg, embryo may be found, but because the cilia are damaged, it may lead to the ectopic pregnancy. The implanted embryo gets implanted there and it cannot get transferred to the fallopian tube. So salpingoscopy some people are doing, and though it is controversial, if on salpingoscopy you find that the cilia are absolutely damaged, there are different gradations of damage of cilia. In my opinion, rather than keep a patent but an abnormally functioning fallopian tube, it is better to remove that fallopian tube and straight away go for IVF, rather than leave that incompetent, non-functional but anatomically patent fallopian tube inside and leave the patient with the risk of a ectopic pregnancy. So, in conclusion, what I would like to tell is, if there is a single side cornual block, in 95 to 99% cases, it is likely to be that this is a cornual spasm. It may not be a actual cornual block. If we repeat the HSG under good circumstances, either with a good analgesia a couple of hours before with slow injection of dye, or under anesthesia, we may be in a better position to go for, we may better know that this fallopian tube is open. Fimbrial block is good as far as the prognosis is concerned. Why? Because surgical treatment is available. We can go for a laparoscopic fimbrioplasty. We can go for a laparoscopic removal of the minute tubal adhesions. Those can also create a good tubo-ovarian relationship, and there are good chances that fallopian patient may conceive normally. But it is a mid-tubal block which is dangerous, which is non-conducive as far as the conception is concerned. So if there is a mid-tubal block, in my humble opinion, that patient should be a candidate of IVF, especially if it is a bilateral mid-tubal block. But before going for an IVF, these fallopian tubes have to be removed. These fallopian tubes should not be remain inside, because it might lead to more chances of a failure during IVF. In next video, we will discuss about what if your fallopian tube is X-ray suggesting of an hydrosalpinx. There is a single hydrosalpinx, there is a bilateral hydrosalpinx with fallopian tube patent, hydrosalpinx with fallopian tube block. Do we need to remove hydrosalpinx before doing IVF? What does hydrosalpinx do to the IVF? These all things we'll discuss in our next video. Before concluding the video, sincere request, please like the video, please share the video, please subscribe to our channel. Thank you. Bye-bye.